This is video 4 on the pain assessment, and in the last slide I was talking about hepatotoxicity and how important it is to make sure that patients do not overdose on Tylenol. It can happen very quickly and very easily. People think Tylenol is benign because you buy it over the counter and people take it all the time. Same with aspirin. My father-in-law likes to take aspirin all the time. He also has some dementia, and he also drinks alcohol. So chances are he's going to have some trouble. But Tylenol is the same because people don't think, they think, oh, it's just Tylenol, but it can trash your liver very quickly. So you have to make sure that patients understand that. The next group of drugs is opioid analgesics and agonists, and they work by stimulating the opiate receptors in the CNS and block the release of neurotransmitters in the spinal cord. They treat both acute and chronic pain, and you can use them as to sedate, and sometimes they can be used in enough strength to actually have an anesthetic effect, and obviously you can become physically or psychologically dependent on these. Side effects include, and again, I'm not going to read all of these to you because you can read this yourself, but you do want to know the different side effects of opioids. You want to know some of the basic drugs within these classes. Biggest side effect probably for opioid use as far as biophysical one is constipation, because remember, opioids slow everything down. So if they're going to slow everything down, they're going to slow the bowel down. So again, this goes back to patient education. Use of laxatives or stool softeners is usually appropriate, and in most facilities when they order an opioid, they order a stool softener prophylactically. If they don't, as when you're advocating for the patient, call the doctor and say, you know what, I see that you ordered Percocet, so can I have some Colace to go with that? Here's some examples. Again, I'm not going to read them, but you certainly can, and I would do med sheets for these drugs because they're going to come up not only through this unit, but also through practice. So I would probably want to know all of these drugs. Then there's opioid partial agonists, and they can be only used for short time. They can have a whole bunch of side effects and stuff, so they are usually used only like in surgical situations. Nubane is used for obstetric issues and any kind of, like I said, a surgical thing, and they're only used in very, very short terms. And then there's Narcan, which, of course, in the news you're reading all kinds of things about Narcan. This is when you use Narcan when a patient has taken too much of an opioid and their respiratory drive has been affected. You can give Narcan. But remember, when you give Narcan, especially to a patient who has a dependency issue, you are stripping them, or a chronic pain issue, you are stripping them of any relief they have. Once the Narcan hits, they will come up fighting. It is a very, very unpleasant drug. So obviously, though, you have to give it because it'll save their life. Throughout these slides, you've heard the word adjuvant. And these are drugs that can be given along with pain medication and sometimes by themselves, and they will produce pain-relieving effects without the opioid problems. Now, they have their own set of problems, but they work. Corticosteroids, dexamethasone is used a lot. It can be used to reduce inflammation, arthritis, lung pain. Tricyclic antidepressants are used for chronic pain and neuropathy. Amitriptyline is one of those. Anticonvulsants can be used. You see gabapentin used a lot for neuropathic pain and for different kinds of chronic pain. And sometimes lidocaine, like lidocaine patches, are used and that kind of thing. So these are all adjuvant therapies, and they're excellent because they make opioid use not needed as often. But again, they have their own issues. So again, I would probably do a med sheet on each of these class of drugs. Now I'm telling you this, I'm not going to be testing you on every single one of these. But again, I can tell you what's going to be on your test, and then I can tell you what you're going to need for nursing. And these are the things that you're going to need for nursing. So the better your foundational knowledge, the better off you'll be. Cancer patients have a different kind of need for pain, and some therapies that they use aren't pain management at all, or not traditionally. Radiation shrinks tumors. By shrinking tumors, sometimes they can relieve pressure and reduce the pain. Sometimes surgical removal, again, chemotherapy, hormone therapies, all of these can be done when there really is no thought for a cure, but they still want to be able to provide the patient with some relief. Back to non-pharmacological strategies. We talked about this a little bit before, but breathing. First line, you want to have the patient look at you and, make eye contact with them and say, okay, I want you to look at me and I want you to breathe with me. Let's take a deep breath in through our nose. Now, very slowly, I want you to let the breath out. Now do this with me, and you just keep doing that over and over. That's the premise of anyone who's had a baby knows this. That is the premise of natural birth, is learning how to control your body and keep it relaxed. If you stay relaxed, pain is far, far less. Distraction, guided imagery, again, we talked about all of these things. Support groups, sometimes there's a spiritual issue and maybe pain is really secondary. Use of hot and cold. All of these things can be very, very profitable and helpful with pain. One thing you're going to see probably when you go into the acute care setting, and as an LPN you will not deal with a PCA, it's patient-controlled analgesia, and this must be regulated by an RN. So this is a pain, the patient has this little clicker, and the pump is set to give, every time they hit that clicker, so many milligrams or parts of milligrams of a drug. It has a lockout, like maybe they can click it every 8 minutes. They might click it and click it and click it, but it's not going to do anything until that time is up. But it lets the patient control their own pain management, which is really helpful, especially in a post-surgical situation. Then there's patient-controlled transdermal systems, and this is when fentanyl, those kind of drugs are given through a machine that puts it into the skin and then down into the dermis, and then the body absorbs the drug in a very slow way. There's also very simple things like patches where the skin absorbs the drug very slowly. Remember, learning all of this about pain, when it comes down to it, you have to believe the patient, and you have to advocate for the patient. You have to assess them continually. You have to administer treatment in a timely fashion. You have to evaluate the efficacy of the treatment and anticipate, prevent, treat the side effects, and then of course you have to document on the pain. Make sure that you are collaborating with other disciplines, like especially if you're dealing with a chronic pain issue, maybe physical therapy. Educate the patient and the family in non-pharmacological methods of pain relief, and again, identify barriers to their pain relief. In conclusion, this has been a quick one. Pain relief is contingent on adequate assessment and reassessment. Use both drug and non-drug therapies. Pain extends way beyond the physical causes. There are spiritual issues, there are psychosocial issues, financial issues. Pain management must be more than nurse to patient. You have to involve, again, physical therapy, physicians, spiritual care, and the family. And continue to teach the patient, and of course, participate in any research that you can, because that will only make it better. So this concludes the pain management lecture. I hope this is helpful to you, and I hope to see you in class.